Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Well, thank you. Welcome to Voices of Otolaryngology. I am beyond excited. I'm jumping out of my seat, if you look very, very closely, here with the Dr. Dr. Nora Perkins.
Sure.
Welcome.
Thank you so much for having me. I'm excited to be here.
Yes, you are our inaugural OTO Forum videocast.
Amazing. You couldn't have started off with a stronger combination here, right?
Let's go.
All right, I love it.
Yeah, but you were also telling me, in full disclosure, that there's somebody who has a better radio voice than we do.
That's true. So yes, my partner Gavin Stetson. It is really hard to beat that like smooth South African. It's not a drawl, but it's very pleasant to listen to.
So does he say stuff like, we were operating, we got in the skull base, there's a little bit of fluid, we just patched it up, everything's okay, carotid's healed, we'll be all right.
Totally.
Yeah, have a good day. And you just walk in, the family's just feeling great.
It's reassuring, yeah. And he ends everything, I'm sure you may credit this, with an onwards and forwards. And I've tried to adopt it for meetings where I'm standing in and it doesn't work.
Well, tell us what you're presenting this afternoon at OTO Forum.
So I am presenting incorporating APPs into a private practice. And sort of the best ways to do that. And our practice in Albany, we have a number of APPs, and we have for a number of years. So I think probably 25 years ago was the first APP who joined the practice. So kind of an early adopter, I would say, at least for the
Blair's Dallas is probably.
Yeah, exactly. And since that time, we've really grown the number of APPs in the practice, partly because we really had a successful experience, but also because we need access. I'm sure like other practices, we don't really have enough physicians to fill the need for our community. So we've sort of used APPs to help fill that void and improve access to our patients.
When I visited you all, your practice is beautiful.
Thank you.
And thank you for hosting me. Unbelievable practice. What you built is very special in the market, in the community. The rise of APPs is exponential or asymptotic. Can you walk our members through that? So early 2000s, you hired your first APP. And how many do you have now?
We are onboarding our 21st and 22nd.
So I actually can't believe that. Yeah. Can you walk us through how you grew?
So I joined the practice in 2011. And at that time, I think they had just hired the fourth APP. So there was an initial between that 2000 and 2011 kind of slow growth, right? You have one, you have two, you have three, four over 10 years. But it had been a very successful experience. The practice had found the APPs were well liked by the patients. They were excellent colleagues, delivering really good care. So it was a very positive experience. I think the change between 2010 and now 2025 has been consolidation in our community of ENTs. So we used to have a number of 1, 2, maybe 4-person practices in the community. And over that 10 to 15 year period, it really consolidated to our group. We have 10 physicians in our group now, and the academic medical center, who has maybe 13 or 14 physicians. And so there was a need in the community for care, and we, having had that very positive experience with the APPs, just continued adding more and more and more APPs because we continue to have patient demand for access to care. I think with COVID, a lot of practices also noticed primary cares weren't necessarily seeing their sick patients. They just didn't have capacity, right? So we needed to sort of take on some of that capacity, and we can't make ENTs quickly, right? But we can bring on APPs, teach them ENT, because I do think that's a critical part to a successful incorporation, and then have them working with us, as our colleagues.
Wonderful. Sometimes I feel obsolete. I could just probably leave and you could just keep going. You're answering so many questions that our members are going to have. So in the first decade, you went from 1 to about 3 or 4 or 5.
Yeah.
And then in the last 15 years, you've gone from 4 or 5 to 22.
Yes.
And could you tell us a little bit about their practice? Do they practice independently? And I know the setup, but if you kind of describe it for
Yeah. So in our practice, the APPs have independent schedules. And we found that to be very successful for the APPs themselves. These are people who have chosen to go into this path of medicine. highly trained. They did not get into med school. They never were interested in that. So they enjoy, at least in our practice, having an independent schedule. We kind of cap that around 20 or 21 patients a day. So we're trying to.
Terrific. So 10
It's excellent.
sessions.
Yes, exactly. And we're not high volume, I would say. Like even my practice, I like to be at around 30 patients a day. So I'm not seeing 40
it's a
or
walk
50.
in the park, 30 a day. But that's what we hear from our,
It's kind of a nice, it works for me. But when we sort of keep the APPs in that sort of 10 a session, it allows them to deliver really comprehensive care. We have a lot of ancillaries in our practice, as you know. We have audiology and hearing aids, we have allergy. And so with a little extra time, the patients can talk about their sleep apnea, they can talk about their hearing concerns, they can talk about allergy and
health conditions.
Exactly. So it's a really nice kind of way to sort of a little more holistically approach a patient. And so they do have their own independent schedules. They see new and follow-up patients.
Okay.
So it's kind of when a patient is making an appointment, they can say, I would like the first available with whomever. They can say, I would like to only see Dr. Perkins for whatever reason. But we definitely have found that I don't think limiting patient type is particularly helpful, because with training, the patient who comes in to see the APP, like let's say they've had 5 sinus surgeries and they're looking for a 6th surgical consultation, right? Not maybe the best setup. But if that happens because the patient says, I want to be seen tomorrow and therefore I'm going to see the PA, that's fine. The PA can say, great, let me get this history. Let me, maybe get some updated imaging. Let's make sure that you're on all the appropriate medical management. Is there an allergy component? We're going to get you teed up to then meet with the surgeon for this, 6th.
Walk me through that example. Yeah. So then in that case, then would they then expedite that?
Exactly. So making sure that everything has been done, because we all know that sometimes we see patients who are coming to us for perhaps the surgical opinion, but they haven't actually done all of the medical stuff we might like them to do, or they haven't had the imaging or the workup that we would really need to sort of have that discussion about surgery. So the PAs in our practice, part of the training is, it's actually, I should go back to this. Our training is about a 24-week training period, so it's quite long. The first 8 to 10 weeks is really just shadowing. So a new PA who's joining our practice is spending 8 to 10 weeks working with all the physicians, the other APPs, to really kind of learn how our practice works, how each individual provider kind of might do things slightly differently. And then there's also an educational component where they're responsible for learning sort of specific disease states along that time period. And we give them resources to do so, including the basic and advanced allergy courses, which are awesome. I can't promote those enough.
And you give them to them, you invest.
Yes.
Invest. And it's an investment. I'm saying it's correct.
It's an investment of time, because during that 8 to 10 weeks, there is no revenue generated by that person, but that's okay. And then during that sort of second, 10 to 12 weeks, they are ramping up slowly with their own schedule. So a little bit like a med student would be perhaps, or a resident, where they're seeing some patients independently and then sort of
presenting. Do you mind walking our members through that ramp up? Sorry, I love how specific you're getting, because these are the questions I get across the country. So about an 8-week onboarding.
Yep.
By the way, the Otolaryngology Core Curriculum in a few weeks will be able to be rolled out to the physician assistants. Just want you to know that.
I think that's
So please incorporate that.
Yes, definitely. I think it's such an excellent opportunity, because a lot of questions that we receive also, just as somebody who has a lot of APPs, is how do you train these people? What resources are available?
That's right.
So I think the Academy having this very clear resource is
And so you do basic and advanced allergy. You do shadowing for 8 to 10 weeks, and eventually you'll add on OCC.
100%.
But then talk to me through, how do you ramp them up?
Okay. So they've started to have their own schedule. They may only have 3 patients in the morning and 3 in the afternoon. So 3 per session, right? So that's plenty of time to really kind of like fully evaluate the patient, be comfortable with the EMR, find a resource. If they need me to kind of review their treatment plan before they even go back and see the patient, for example, if they say, hey, I've reviewed this chart and I want to make sure I'm on the right track with this plan, they can find somebody to review it with. So initially they're seeing 3 a session.
Do you have a lead or head physician assistant?
We do.
So they could maybe go there as a resource.
Exactly. And so we do have sort of some set in place resources, right? There's a lead physician assistant. There's actually an educational lead physician assistant who's kind of a separate person. And then there's a number of other more experienced physician assistants. There's also a number of physicians. And I'm sort of getting off track, I apologize. But one of the things that makes this work is we have an incredibly collegial culture in the practice. And what I mean by that is there is never, ever any negative feedback for a question,
Pull me aside. I have a question on a 10-minute workup. You'll help.
100%. And I think that's really critical to making this work, because if somebody, it's kind of like working with residents. If somebody's hesitant to ask you a question, that's not a good culture. That's not going to be successful. Mistakes can happen, things can be missed. But if it's a really open culture where questions are encouraged, collaboration is encouraged, then I think that it's a much safer environment, because I know that there can be hesitation of, well, geez, this person didn't do a 5-year ENT residency. Like, how am I going to trust them with the care of my patients, right? And I think the way that you do that is through education, but then also through creating a really, really open culture where they are not hesitant to have you take a second look at a weird ear, or even like, this looks funny on the larynx, and it's the pediole. It looks funny, right? If you've never seen that before, if somebody has a healthy larynx and you've only seen abnormal larynxes,
it can be really nice to just kind of have another set of eyes.
And the buck stops with you. You are a huge resource in the community. If I send a family member to you for hoarseness, I expect that if there's a dysplastic lesion, you'll find it.
Exactly.
And I might need to call in a partner or another person.
We did the same thing.
Exactly. Nora, you come take a look at this. So you ramp them. It's now 8 to 10 weeks.
Yeah.
You ramp up 3 in the morning, 3 in the afternoon.
Yes. And then they're kind of slowly ramping.
Sure.
they kind of ramp, I would say, to variable degrees, like the speed changes. It's a little bit personality dependent. If this is a new graduate who is not only learning ENT, but learning how to practice, right? So that might be a little bit of a slower ramp up. If this person came with 15 years of experience in primary care, then they're probably more able to ramp up quicker.
And you open these slots for anything, or do you focus on?
We open up for anything.
Yeah, from day one.
Yep, when you're not.
So they could see a 90-year-old, they could see my mother, and then they could see my
6-month-old. Yes, exactly. Yep. So they can see everything. And we do have some APPs in the practice who have kind of focused on pediatrics.
Neat.
And so they do spend some dedicated time with the pediatric APPs. There's some additional educational resources that are sort of pediatric focused as far as like comment management problems and pathways and things like that.
Then those templates could be constructed in that certain way. So, right?
And so,
You have the kid who has, let's say they have something simple, right? Recurrent otitis media. Okay, let's make sure that we have all of the questions that we want to ask about, like, did they pass their newborn hearing screening, right? Did they have NICU stays? All those kinds of things that are like silly, like when you think about them, but they're important questions, and they're things that you expect to have been asked and answered.
so just making sure that they're following of
I standard, yes, but then you drive quality for your community, for audiologists, for the referrals.
Exactly.
We have algorithms in our head.
Yeah, as in law.
Exactly, and they're helpful. They help they help make sure that we aren't missing things, that we're following, a cadence.
Where did you do your training?
In Albany.
So I trained in Albany. I was actually super fortunate to train with the group that I joined. I left for a short period and then moved back because my husband is from the area. So I moved back and I knew pretty much who I wanted to join.
When you're a native
Albanian? I don't know. That's probably not right, but yeah. Yes,
Okay,
exactly.
cool.
Yeah.
The reason I ask is I remember my co-fellows in fellowship. I did fellowship at Children's Boston. So David Perry and Kimsey Rodriguez. David Perry, Arizona private practice. Kimsey Rodriguez, academic. Dave, Kimsey, and I would round, and patients would give Dr. Rodriguez, Kimsey Rodriguez, chocolate. And on Christmas, she got all these cards, and Dave and I got nothing. We just looked at each other. I mean, we never won teaching awards, but people loved Kimsey.
Yeah.
I bet you patients love the physician assistants, and I bet you they call, and no offense to you, but they don't want to see me. They want to see Joe Smith, the physician assistant.
You are absolutely
Right?
I mean,
You're absolutely right. So patients, like let's say somebody has been working with a physician assistant in the practice for a number of years on their allergy management, and something is different, right? That they've got a new symptom, and the PA says, I do want you to see Dr. Perkins at the next visit. Let's just get another opinion, another set of eyes on this. Great. They see me, and then they say, okay, it was nice to meet you. I'm going to go back and see. They don't want to see me. They are super happy with the person they've been working with. My visit was probably more brief. It was not as comprehensive. I didn't ask about the grandkids, so they really
do develop really nice. Just as a random comment, I'm obsessed with AI. I use Claude. And so when I put things into Claude, you ready for this? Claude will say, you may need to work on your tone. You lack empathy.
oh my goodness, that's incredible.
Yeah, no, I'm not saying you don't lack empathy.
No, but I love that feedback, right?
Yeah. But the physician assistants will spend time. Yes. They'll look at it holistically. You're absolutely right. So can I call your practice and ask to see a specific?
Yes.
That's amazing.
Yes, just like you would ask to see a specific physician, you can ask to see a specific physician.
But that doesn't cannibalize your own practice.
No.
there is a demand, and I think I would be really surprised. Maybe in certain geographies, right, in really dense metropolitan areas where there's lots and lots of ENTs. But I would say in general, for most practices, there's a waiting list to see the physician, right? And so we are not only not cannibalizing, but again, the culture of our practice is that we see each other's patients. So we are not possessive of our patients. I may see one of Gavin's patients, and I may say, oh, hey, you need to have some type of surgery. He's like, great, do that surgery. So we're not possessive of our patients at all. That, I think, is maybe part of why the culture works for us to see each other's patients, the APP's patients, and it's not possessive at all.
Yeah, so I'm obsessed with numbers and quants. I'm sure call that a nerd. I think it's an affectionate term of endearment. So I'm going to nerd out.
I'd call it.
You're so funny. So I'm going to nerd out a bit. Tell me if you lose the analogy, because I don't want to talk numbers. Everything is regional. Let's call the base salary of a physician assistant X.
Sure.
Okay. And your partners, do you mind, and we don't have to talk about it, but do you mind, how are they compensated, and how does the pie grow? How do they win?
Yeah, so that's a great question, and I do think it's important to know. So in our region, we do have a base salary.
So X.
X, and we try to be very consistent based on years of experience. We try to sort of be
Transparent.
And are you consistent with the academic center too? Yeah, have to be. Recruit.
We do have to be. I will say that we acknowledge that our first year salary is probably on the maybe like mid to slightly low end
of what the academic would be.
Exactly,
So what's the
because
upside?
and we also talk about, we have this 24-week training period.
They don't do that.
They don't do that. Many of these APPs have had experiences where they're now a hematology, provider.
Day 1 or 2 thrown on the floor.
Let me interrupt you because I want to say that again. You actually said you have a half year.
Yeah.
I just thought I want you to know that.
Yeah.
24 weeks. I ain't no genius.
6 months. Yeah.
You're spending a half year investing.
Yeah.
And for that first 8 to 10 weeks, there is literally no revenue generated.
So 2 months, nothing.
No
And then the
billing,
other
no
4,
nothing.
So you're underwater.
And then yes, but it's an investment. Again, it's an investment in your patients, because truly they're getting access and they're getting great care. It's an investment in your practice because
why don't they leave
ultimately,
to
so I think that's one of the challenges, right? Retention. We want to sort of try during our interview process to determine if somebody's interested in a long-term kind of marriage, right? Are you interested in this long-term relationship with us? I do think a little bit that first year salary not being the highest
Actually helps selects for the right culture. I think
because they know that, hey, I'm going to stay here.
we're investing in you. Yeah, it's an educational component.
we're aware that our first year salary is less than if you go work in the hospital. But by the way, you're also working nights, you're working weekends, you're working holidays. In our practice, there's no nights, there's no weekends, there's no holidays.
We're not the practice.
We're not the practice for you. But then we talk about years 2, 3, 4. So just like a new physician joining the practice, we're going to give you kind of like, here's what you can expect year 1.
Here's what you can expect to your
So what can they expect? So X is their base.
So X is the base. After their first 3 months, they are now eligible for a quarterly bonus. So this is everybody, every physician assistant in our practice. And I say physician assistant using it interchangeably with APPs because
Ours, that's acknowledge that. So 3 months. So I've done every 8 to 10 weeks. I've just studied.
yes. So for your next 3 months, and just every 3 months, every physician assistant is eligible for a bonus. Now, for your brand new person who has just started seeing patients, they're probably not going to get a big bonus in that first 3-month interval because they just really haven't met some of the KPIs that we use to
Sure, but they're still getting a spreadsheet, fully transparent.
Yes.
Why is Nora here and why is Rahul here?
Yes, exactly.
That's so cool.
That took a little bit of time to develop. I know law of collections. No, it's not.
So interestingly, we considered using collections, but we didn't really feel entirely comfortable with that. We didn't really want to incentivize people to just be going for high collections, and their bonus was based off of that. So that our lawyers didn't love that. We didn't feel super great about it. So what we ended up doing was creating KPIs based off of our physicians. So we used our own group of physicians to kind of get normative data. And we measure things like, procedures per patient, which includes endoscopies,
Cerumen removal, controlled epistaxis.
You measure that, not the RVUs associated with it. It's just the absolute.
And a little bit, it's sort of like, okay, where are the physicians? Because that's sort of about where we.
Yeah, fair.
And then if you're really below that, that's kind of concerning, right?
Then you're missing diagnoses.
people, right, exactly. Or if you're really high, that's actually also a little bit concerning.
So you reward the band.
Yes,
Exactly.
So we look at things like that office visits kept. So we're trying to kind of encourage people to take add-ons. So we have an urgent care in our office, and we do have physician assistants who are dedicated to cover the urgent care, but we want a culture of yes. And this is something that I noticed immediately when I joined the practice. If somebody calls up and says, hey, can you see my patient today? They've got something weird. It's always yes.
So how does office visits kept define that? So I'm a physician assistant. I have 10 and 10 in my template.
Yes. So let's say you have 10 and 10 in your template. You get a kind of full points towards your bonus if you kept 17 of those patients. And what that means now, some of that's out of your control, right?
Yes.
Patients who no-show. Yeah. But if somebody cancels and you say, hey, I'll see one of the people from urgent care.
Do you know how fair that is? See, you're telling me to give you 5% notion to get high?
Yeah, exactly.
And if I want 4, give me those urgent care?
We're trying to make it reasonable. It's terrific. Achievable.
Access.
And also just, what it is. So if you didn't keep the
why I didn't.
I'm going to now pull some people from urgent.
So those are two the main KPIs for your physician.
Other things that we do, we have sort of an audiology category, and that includes sort of number of audiograms, conversion to hearing aids, similarly with allergy. And then the last one we kind of consider it should be a gimme. It's the time frame between your visit and when it was billed and the note was completed.
Oh, that's a freebie.
And we want that to be within, I think it's 24 hours or 36 hours or something reasonable. So everybody should get that, but it's also just that's good practice, right?
Yeah. So let's go back to NERCA.
Yes.
This is phenomenal, by the way. I was going to try to keep this to 20 minutes, but I don't care. Sorry isn't so fun. Don't feel sorry. You have an hour lecture today. You made a lot right out. Thank you. This is awesome. So physician assistant every quarter
has an opportunity for a bonus. So you have your salary. After that? Yep, it is. So they receive it kind of almost like you would our audiologists get commissions.
It's a terrific feedback mechanism.
Yes. And you can see if I didn't hit my full bonus, why didn't I? And what can I change in the next quarter so that I can hit my full bonus?
My son plays varsity baseball, and I try to make a lot of his games. Yeah. So if I cut my template back to make the game, during baseball season, I will have less.
Yes. And you know what? That's okay because you're aware of it. So even in, like make it up in the off season. Exactly. And I think
transparency is so important. It doesn't have to be, again, we weren't entirely comfortable sharing collections, being transparent with, here's what you collected. That becomes a little bit...
Good point.
A little bit weird, and there has to be an understanding of what the overhead is and what the cost of goods are and things like that. So it gets a little bit, I think, difficult unless you're really in the weeds of running a practice.
So X is their base.
Yes.
So are you able to tell me what percent is at risk? Is it point but no bags, 0.0?
It's probably going to be, you're going to make me do math now. Maybe maybe 20% over the year.
Yeah, right. So so then. Well, so it's going to be 1.04x or 0.0. Yeah, I got it. So 4% a quarter. That's terrific. Thank you. And I think that'll really help our members.
Yeah.
So the total at risk is 20%.
Yep.
And then you said in year 2, 3, 4, they make more. Is that because you give increases for tenure the longer you're there? And again, just use X. I'm putting you in an uncomfortable.
No, it's fine.
So yes, so we kind of annually do merit bonuses. That's sort of like practice-wide across the practice. And so the APPs, fall into that category. Like, let's say you're year 5 and you're going into year 6. There's sort of an amount. But then there's also, we do look at like market adjustments just to make sure that we're sort of.
So every now and then you might have a step up.
Exactly. But between years 1 and 2, we're recognizing you've completed your training, and we're going to give you, like, let's say you were at
X.
45% of MGMA or something like that, right? You're just a little below. Well, now you're probably going to go up to 70% or something.
My
so,
gosh,
like, it's a pretty big
that's
jump.
huge.
It's a pretty big jump because we're aware that training period is over. So where you weren't collecting much for 6 months that first year. And I do think that, I don't think money keeps people, but I do think that you need to be aware that it is important to make sure that you're competitive in your market, that you are, you might not be the highest because, again, if I'm working thoracic surgery, nights, weekends, whatever, overnights, then I'm probably going to be higher.
Yeah.
But I think you need to be aware that, your salary's competitive, and if your culture's good, your work-life balance is good, I think those are the things that keep people. If people are happy, again, having an independent practice, I think is generally a fulfilling thing. We want to provide medical care. I think it can be really challenging for APPs to be on that sort of shared schedule where they're not really independent. They're almost working as scribes or kind of like, as a resident where you're sort of going in and doing the initial thing, but you really don't have any ultimate control of the plan in the office visit. I think that can be frustrating, and that may be an area where retention could be a challenge.
Yeah, this is unbelievable. So let's continue. As I don't have a piece of paper in front of you, so I'm going to add another variable. So physician physician collections is a Y. Mm-hmm. Physician collections is a Y. What are the APPs across the country? You don't have to be to your practice because you benchmarked.
So
about 0.3, 0.4 collections.
our practice is different than that.
Yeah, so, and it doesn't have to be for yours. And let's give us an idea.
Yeah, so I would say
Our APP collection can be close to Y.
Got it. Fine.
Yes. Or let's say 0.5 of Y.
Yeah, fine. So half, yeah, okay.
But it can reach close to it because of utilization of ancillaries.
Sure.
Yeah, that's the variable that I think.
Because the downstream utilization or audiograms, et cetera. Right. How do you invest in the APPs past 6 months of onboarding? So I'm 10 years into your practice. How do you continue to invest in me as an APP?
Yes, so they do get CME money I think it's maybe, do you want me to tell you the amount? I think this is fair.
Yeah.
It's like $5,000 every 2 years for CME.
That's
so
a huge amount,
it's
by the way.
Yeah, I think it's a very
That's a huge amount.
reasonable, kind of offering.
How do they use that? Where do they go?
So they have to use some of it
Say
for
it, Nora,
ENT.
annual meeting.
Yes,
Say
of
it.
course, the annual meeting. No, some of it has to be ENT specific. So like going to that ENT for the PA training course. We've had many PAs attend that. But then some of it can be PA specific. So if they want to be involved in like the state PA society, they can use it for that as well. So it's a little combination of those two things.
And the lead PA and education PA help adjudicate that. I don't want them attending ortho courses and leaving me to be
Right. But I do think there's they have to recertify in general things. So there is a need to maintain some of that general knowledge. But I think, again, we do want them doing ENT specific courses as well.
So you
the other
invest in
thing
them,
I
yeah?
should throw out there, so for our lead PA, she has goals that kind of like any manager would, a manager of a department, and those goals do have a bonus tied to them, so that's unique. And then the person who's running the education for the PAs also does have an additional stipend for that.
And do they have a day or have... Yeah, the admin.
Yeah, the manager has a half day a week of admin time, and I think the education maybe has like a quarter day or a half day every other week.
Where do they sit in the governance structure and board meetings?
Yeah, so we don't have them at, for example, like, in our governance, we have an executive committee and then we have the partners. So they're not involved in those immediate meetings, which I think is reasonable.
The executive committee a subset of the partners?
Yes,
Okay.
it's a subset of the partners. But we do have, our lead PA, the manager of the department, meets with our CEO, who's Gavin, on a I want to say every other week
I thought it'd be
cadence.
daily, no problem.
I know. Probably every other week or once a month. And then
To address needs and
exactly. And then we have a provider meeting every month that brings all the doctors, all the PAs together for some education and also just kind of like concerns. So if there's things that need to be reviewed with the whole practice, all the providers, we review that. And then quarterly, we do what we call pod meetings, which is sort of all of the PAs, and pods are just kind of the way our practice is set up, like, hallways or corridors or whatever. The PAs who are in those pods meet with Gavin and myself and just review like any kind of, it's almost like the airing of the grievances, right? It's sort of like, are there concerns? Are there issues? Are there processes that you've seen that are not working? Do you have, solutions that you think would work better? So it's really just meant to be an opportunity on a little bit of a smaller scale to kind of like meet with Gavin and myself.
If I was to go to a grocery store or a ball field, a baseball field in Albany, and I ask about your practice and ask about the physician assistants, what do you think people would say?
So I think it would be a very favorable experience.
I'm sure they'd rave about it.
So we use a lot of reviews, right? We solicit reviews and whatnot because, like it or not, I do think that's important, right? And our PAs probably
They do better than
they
me.
get at least as many reviews as we do. They are getting reviewed regularly. Patients love them, yes. And we sometimes, we try to share this with just the practice when it happens, but people will specifically thank a PA, even through urgent care, because urgent care, brings in things that sometimes are not ENT, right? People come in for example, somebody might be sort of in some sort of AFib, like new onset AFib,
God.
right? Because they're short of breath.
Yeah, I'd send them out the door.
We do. We call EMS.
I call Nora.
We do. We send them out the door.
Knows how to manage
They know how to manage it better than I do,
Read the
frankly.
EKG.
Yes. Well, not even, but they just, they take their pulse, and I'm like, oh, good call. That was a smart idea.
Yeah, we go right here to take
Exactly. So there's just things where the PAs are delivering
Value add.
incredible care, in sort of helping expedite care for patients, and patients are really, really appreciative, and they reach back out and, call the management and say, hey, thank you. I want to shout out this person for helping out my dad who came to your urgent care. Yeah, it's really impressive.
When we thought he was having vertigo.
Exactly. We thought maybe his asthma was acting up or his, his nasal polyps, right? Yeah, exactly.
Wow.
So.
What isn't going well? I took 36 minutes to be your friend.
Take it out.
What doesn't go?
So I think one challenge that we have, like we worry about retention, but I will say that our rate of people leaving, unless they're moving geographically,
forget those. I don't want to talk about
is
those.
very, very low. And so I think that that's going well, but I do think it's a concern. We don't want to.
Especially as you scale.
Yes, exactly. So there's a challenge with sort of like finding that right size. We have 2 more physicians joining us in the fall. And, I feel like for us, we're feeling like that sort of 1-to-2 ratio feels pretty good. When it starts to get, like if a lot of the physicians are operating or out of the office, it can get a little overwhelming for the physician who's there to be the resource. So right sizing, I think, is a little bit of a challenge. Also, geographic locations. Our office in Albany is huge, right? So we have 54 exam rooms or something like that. So there's always people there for help, for assistance. We have one other office that is smaller. We have about 4 to 5 providers there. But on the rare occasion, some holiday or something, if somebody is there alone or, without a physician, like that's something that we're trying to navigate and make sure it's safe and everybody feels comfortable. We have a 3rd location that's opening. So, as we sort of get a little geographically less concentrated, I think that can be a challenge. There was another area that I was trying to, it's escaped me. Yes, retention, geography.
Oversight.
Oh, yes, here's a good one. So I had a wonderful opportunity to talk with one of the residents who is attending the OTO Forum, which I love, right? And we were talking about the APP talk that we're going to have later. And she said, I had a concern about a practice I was looking at because they said that I would be responsible for overseeing 4 of the PAs or the APPs.
Right.
And I don't know what that means. That sounds like a lot for me when I'm just starting to learn how to practice.
Great point.
And I'll say when one of the physicians who's joining us this fall, that was a big concern, was sort of what does this mean? What is the legal implication? And what I have told all of these, the residents, this is kind of like working with your junior residents in that you're actually used to working with people who are, maybe not as experienced as you are, but they're your colleagues. And so you're used to doing this. Obviously, legal implications can vary state to state, but as long as you're maintaining safety and compliance with all those things, I think that's reasonable. I don't think that's an area of concern. But I think just thinking about it like you're working with your 2s, your 3s, you're working with your residents who maybe aren't quite as experienced as you are, but they're incredibly capable, they're incredibly smart, they're incredibly motivated. And when you kind of compare it to that, I think it's a lot more comfortable. We're used to that. And we like that. We like teaching and collaborating and working with people. So I think it can be a really nice opportunity to kind of teach.
And remind me, for the audience, my understanding is your advanced practice providers do everything. They'll do ceremonectomy, they'll do flexible nasopharyngoscopy, they'll do endoscopy, correct?
Yes.
Okay. Other than procedures, perhaps.
Correct. Yeah. And again, I think that can vary by state. Absolutely. And also observation.
Scopes, control of epistaxis, peritonsillar abscess drainage. Those things probably are the mainstay of their procedures. We had a PA who moved to New Mexico, unfortunately. Lucky to whoever's in New Mexico working with her. But anyway, she was an audiologist who had been trained previously with microscopes. So she would do like myringotomies, or she would do like transtympanic injections. So that was really unique.
Cool. Yeah.
So you might find somebody who came from a procedural background who could do a little bit more.
I forgot to ask you, what is your role in the practice vis-a-vis advanced practice providers? Is it your passion? Are you the liaison?
Yeah, I am the liaison.
Sorry, we should have done that.
No, that's fine.
And it really, I do feel strongly about it, because I think it's a need for healthcare. I think if we're going to sort of be able to provide care to people in a timely manner, that we really need to embrace this sort of extension from physicians to include APPs. I don't think it's a threat. I think it's an opportunity for us to just kind of open our own schedules more, be more efficient, offload some of the stuff that maybe I don't need to be seeing, your 6-month allergy follow-up, So I think it can be really helpful, personally as a physician. I think it can kind of relieve some of the stress that we feel. I think it can be really, really beneficial as far as work-life balance. I think for patients, access is incredibly improved when we just have more providers. But again, I think it's really important for those providers to be well-trained.
How much of your time does it spend as oversight? If you want to do daily, weekly, monthly?
Probably weekly. I'm going to say maybe like 2 to 4 hours.
So a real amount, but that's because you have 2 dozen.
Yes, exactly. And that's not even like direct oversight.
No,
that's kind of,
exactly.
Yeah.
One more question. What do you see as the future, and are we able to recruit APPs? How is the market?
Yeah, so the market...
Forget about you all, just overall.
Of course. Good? I think it is good, actually. So Dave Mellon was just talking about audiologists and the challenges of just there's not enough audiologists. But I think there are increasing numbers of programs training APPs. I think it's become sort of a very visible field that people know about. So people are choosing after their undergraduate to go into a program to become an APP. One thing that I think has been very helpful from a recruitment standpoint, we partner with a lot of the local programs to offer an ENT shadowing experience. Because like any training program, it's always a challenge to find places for your students to go and shadow. We found it really helpful for literal recruitment. So people who decide, I really like this, and we've had this prolonged interview with them, we like them, so they can join our practice thereafter. Or if they go into the community as a primary care physician, they know us, they're familiar with us, they're an excellent referral source.
Way, it's a win. Yeah, I wonder, I'm looking at our team here on the staff, I wonder if the Academy or Otolaryngology should have a booth or some way in their national meeting. I think Uncle Sam, we want you. Yeah, they need to know what an amazing specialty we have. Yeah. Just as we reach out to med students. I don't know, what are your thoughts about that?
I think it's a really smart idea because ENT, right, we're so small.
15,000.
And people don't really know what we do necessarily. And if they didn't happen to either have an ENT problem or happen upon an ENT shadow experience.
We won't get the best and brightest.
Exactly. But if they have an opportunity to come to an ENT office, People like it. I mean, listen, we're great, right?
But your turnover, I was going to say, your turnover must be, other than those leaving, like New Mexico Charge, it must be very low.
It's low. It's incredibly low. Yeah. Which is,
I can't thank you enough. Anything you want to end with for the group? We're going to have our goodbye. I'll tell you that in a second. But anything that you would like?
I honestly, I think we've hit all of the points. But the only thing I would say is, I definitely would encourage people who are on the fence to really consider this option of adding APPs to your practice. Gavin, myself, we are all happy to talk about this with anybody because I really do think it's going to be a critical part of us maintaining independence and staying successful in the future.
By providing access, because if we don't provide it, others will.
Yes.
And we're seeing that when we talk about scope of practice.
And also, this allows us to make sure that the quality of the care meets our standards, right?
Love that.
Because we found, like with our urgent care example, the quality of care that patients are getting for ear, nose, and throat urgent care complaints in our practice, is incredibly higher than just going to a regular urgent care. And that's not saying anything against regular urgent cares. They don't have scopes. They don't have like the ENT specific knowledge that we have, but we're providing a higher level of care. And so by kind of embracing it, we can control that quality, make sure our patients are getting the kind of care that we think they deserve.
And we always end these podcasts with a goodbye. And I think we both know how we're going to say, what are we going to say at the end? What does he always say? Onwards and forwards. Oh, you wanted to say fired up? No, we can say rally, go
onwards and forward.
Onwards and forwards. Thank you very, very much. This was fantastic, super helpful for our members. This is Dr. Nora Perkins from Albany. Please reach out to her. They are incredible friends of the Academy, and I think you encourage, right? Yeah, Joe.
Oh, we do. Yeah. Please reach out.
Thank you very much. Yeah, thank you. Thank you.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.